Hi, I am Dr. Murugan, Professor of Radiology and Head of the Department of Radiology, Sree Balaji Medical College. Topic of discussion today is bone infections, and the objective of the study is to understand the radiological features of bone infections so that you identify the lesions early and treat the patient early so that the outcome of the treatment is good. Okay, now we'll start discussing about the bone infections. Now, bone infections are called as osteomyelitis. It comes from a Roman word that osteon means bone, melios means marrow, and itis is inflammation, basically a bone marrow inflammation. Now, these inflammations and infections are categorized under three broad headings: pyogenic osteomyelitis, tuberculous osteomyelitis, and infections that can present at birth called as congenital infections. Osteomyelitis incidence wise, now these are very common in children. That is, commonest age group is said to be 2 to 12 years of age, and it is more common in male. The routes of infections are basically two routes. One is hematogenous, the second one is the direct inoculation, which is either through the surgery or through penetrating traumas and punctured wounds. The hematogenous route passes into the organisms, passes into the bone through the nutrient arteries, and they settle down at the capillaries which are located at the metaphysis of the bone. Those organisms multiply, they form edema of the bone, and then necrosis of that area, pus formation, and resulting in radiological features which will be manifested after a few days. And in the younger children, the cartilaginous bone is the one, cartilaginous growth plate is avascular, so it prevents the infection from the metaphysis to the epiphysis. The common organisms that we come across are, in neonates it is streptococcus, children, that is older children, it is staphylococcus, drug addicts pneumococcus, sickle cell disease, patients with sickle cell disease, it is salmonella infection. Why salmonella infection is more common in sickle cell disease is that these people are more prone for bowel infarctions, thereby allowing the organism from the intestine to the blood circulations. The common locations which can come are tubular bones, more commonly in the femur. Next comes the tibia and fibula. 75% of the bone infections occurs in these. The flat bones are less frequently affected. 25% of the vertebral bodies and iliac bone, in 25% of cases, vertebral bodies and iliac bones are affected. And in neonates, metaphyseal infection often progresses to the epiphysis also. Children, as I told you earlier, the growth plate prevents the metaphysis infections to extend onto the epiphysis because it becomes avascular then. The adults, it is primarily the epiphyseal infection with the subchondral extension. Now, radiological features, it is discussed under four categories. One is plain X-ray, CT, MRI, and nuclear medicine. Plain X-ray features are often delayed by 2 to 3 days time. The initial presentations will be only clinically based on the pain and the swelling of the limb. Now, radiologically, earliest sign will be the soft tissue swelling and the loss of fat plane in that region of infection. And then features start appearing in the metaphysis that occurs earlier as an osteopenic area, Then it progresses onto the abscess and extends onto the cortex surface. The osteopenia stage will appear in about 3 to 5 days time, whereas the cortical changes and the periosteal reaction will occur only after about 7 days of time. In this, the plain X-ray shows a typical bone destruction with a periosteal bone reaction as well as soft tissue changes, that is, the loss of fat plane and the increased radio opacity of the soft plane. Then the plain radiography shows periosteal elevations in the bone and osteolysis, that is demonstrated as a osteopenia of the bone. Now, once the disease starts progressing from that stage, it manifests as a dead bone of the infected area. That is called as a sequestrum. The dead bone is radiodense in plain X-ray, and this is surrounded by inflammatory changes in the bone marrow and a thick sheet of periosteal reaction, which is manifested as a thick bone of cortex overlying the infected area. Now, there is a radiolucent defect in the X-ray which are showing the area of exudate expulsion from the marrow cavity into the soft tissue plane. This X-ray shows the dense sequestrum and the thick periosteal reaction forming a involucrum formation. The next slide shows the MRI features of sequestrum. The involucrum is seen as a thick cortical bone which is irregularly arranged and it loses its normal signal intensity. The marrow changes are seen as bright marrow with an expulsion of the inflammatory exudate from the marrow into the soft tissue planes, which are shown as hyperdense areas behind the lower end of the femur. Now, Penumbra sign is said to be characteristic of subacute osteomyelitis of the bone. Now, how it appears is the vascularized granulation tissue around an area of intraosseous abscess is seen in MR as a Penumbra sign. Now, this picture shows you the typical Penumbra sign. In chronic osteomyelitis, the Broadus abscess, it is called as Paradisopsis. Now, radiologically, it can manifest as a sclerotic rim with a central hypodense area which is depicting the abscess. Now, there will be a tortuous channel which is extending towards the growth plate, and that is said to be pathognomic of the Broadus abscess. Now, typically, these lesions are located in metaphysis or diaphysis of the bone. Overlying thick dense bone and sinus tract adds on to the specificity of the diagnosis of Broadus abscess. Yet another case of Broadus abscess where the patient presents with the soft tissue swelling and skin discoloration over the lateral malleolus, and the X-ray shows a radiolucent bone defect adjacent to the tibiotalar joint. In CT scan, you are able to see the extension of the epiphyseal abscess into the tibiotalar joint, and the last picture shows the treatment with the sclerosing bone cement with antibiotic mixture. Now, a case of Broadus abscess, X-ray shows a sclerotic rim with the radiolucent area, and this has to be differentiated from osteoid osteoma. How do we differentiate this? Broadus abscess normally can cross 1 centimeter size, whereas osteoid osteomas are lesser than 1 centimeter. And in Broadus abscess, the center is radiolucent. In osteoid osteoma, the center is radio-opaque or radiodense. Now, we'll go into another specific type of osteomyelitis that is called as Sclerosing osteomyelitis or Barre, and it is a specific type of chronic osteomyelitis. It mainly affects the children and adult. It typically affects the mandible. Common features are the primary being a odontogenic infection arising from the dental caries. The sclerosing osteomyelitis is seen in CT scan as a diffuse sclerotic bone expansion with an adjacent swelling. The next slide, it is a CT of 7-year-old girl with sclerosing osteomyelitis, where it shows a dense thick bone with irregular margins and a soft tissue swelling. MR features of osteomyelitis are primarily picked up by marrow changes. That is, the inflamed marrow will appear hypointense on T1 and hyperintense on T2. So, on contrast administration, this changes the contrast, enhances the bone marrow, and it also shows you the abscess margin very clearly. The periosteal reaction and the adjacent soft tissue inflammation can be depicted. In nuclear medicine, we have two nucleotides which can detect the early infection. One is technetium-99m MDP bone scan, and another one is gallium scan. Gallium-67 is 100% specific, and whereas the technetium-99m MDP scan is done in 3 phases, that is during angiographic phase and blood flow phase and delayed phases. The persistence of the abnormal pickup during the delayed phases is specific for inflammations. There are few mimickers of osteomyelitis which can take up a positive nuclear uptake, that is occult fractures and osteoid osteomas. Now we'll come to tuberculous osteomyelitis. Now the most common site of skeletal tuberculosis is spine. Most common site is dorsal lumbar vertebra. The modes of spread into the dorsal lumbar vertebra are through Watson's venous plexus, and there the types of infections are either closer to the vertebra called as a discovertebral involvement, or anterior longitudinal beneath the anterior longitudinal ligament, which is called as an anterior involvement, or paravertebral involvement, subligamental involvement. These are all the common sites where it can involve the vertebra, and discovertebral involvement is seen as a earliest lesion with the adjacent discal involvement. Radiographically, it can manifest as bone destructions first. It is seen closer to the disc with resultant loss of disc height. The presence of bone destruction with the loss of disc height is characteristic of tuberculosis. In metastasis, there is no involvement of the disc space. As it progresses, it forms the gibbous deformity when there is an anterior involvement. Anterior involvement results in loss of disc height, the vertebral height anteriorly, thereby it forms a gibbous deformity. When the lesion involves the anterior and posterior planes equally and the disc height is reduced parallelly, it is called as a vertebra plana. And after this infection extends onto the paraspinal spaces. It forms a large paraspinal abscess with extension into the psoas muscles, resulting in psoas abscess. Now, some of the demonstrations with X-rays of the spinal lesions. Now, the first X-ray shows a lesion in D11 vertebra, which is seen as a reduction in the vertebral height in AP projection. Lateral view shows the increased density of the vertebra with the adjacent discal reduction, which is typical of tuberculosis. As the lesion appears progressive, then the late features will be a gibbous formation, which is seen as in this picture. Now, this is an X-ray which shows the cervical vertebral tuberculosis. You can see the height of both the vertebrae, affected vertebrae, are less than the height of the vertebrae above, with the loss of disc space in between, and the prevertebral soft tissue space is widened at that area. Note the posterior elements of the vertebra are remaining normal. In this MRI picture, you are able to make out the epidural spread of the abscess by the infection, as well as the prevertebral spread of the abscess, which is very clearly shown in MRI. the normal hydration of the disc is also lost with lot of edema within the disc space. This is the progression of the disc infection of the vertebra, wherein you are able to see the collapse of adjacent vertebrae right from D9 to D12 vertebra, and resulting in a gibbous formation, which is seen clearly by the clinical picture. At another case where vertebral infection is shown as hyperdense signal from the vertebra, the paravertebral spaces showing bilateral psoas abscess, and the adjacent disc space is also involved. This picture shows prevertebral soft tissue widening of tuberculous abscess from the adjacent bone infection. Different manifestation of a tuberculosis. Here it is purely a sclerotic vertebra with the destruction of the right inferior aspect of the vertebral body, and the vertebra appears sclerotic. The primary is, as shown in this picture, is typically a cavitary lesion in the right upper lobe with the fluid level and fibrosis. Now, tuberculous infection of the bones of the hand is called as a pyogenic. This is expansion of the bone with the lysis of the medulla and cortical bone thickening, soft tissue swelling all around the finger. This is a differential diagnosis for this is tuberculous dactylitis, and sarcoidosis is a close mimicker of the tuberculosis also. Now, between pyogenic osteomyelitis and tuberculous osteomyelitis, how to differentiate is, now in the pyogenic osteomyelitis, the onset is always acute and dramatic, whereas in tuberculous osteomyelitis, it is an insidious onset and the progression is very slow. The sequestrum formation, sinus formations, and the periosteal reactions are more common in pyogenic infections, whereas psoas abscess and osteopenias, osteoporosis are more common in tuberculous osteomyelitis. Bristolosis is considered as a close mimicker of tuberculosis. Now, this has to be ruled out before committing as tuberculosis without a tissue diagnosis should not proceed. Now, being a native disease, this is called as a mycosis, which is called as mother of foot. It is a chronic granulomatous fungal infection of the foot, predominantly a soft tissue involvement. The bones are relatively spared or showing destructive changes. Classical MR changes are dot in a circle sign, which is very characteristic and diagnostic of mother of foot. Now, we'll go on to the congenital infections. Now, these are in congenital infections, the rubella and syphilis predominate. Now, they are manifesting as changes in the proximal tibial epiphysis, that is, destruction of the medial aspect of the proximal tibial metaphysis, along with the periosteal reaction, is said to be a characteristic feature of syphilis. In rubella, the periosteal reactions may not be there. Now, there are three congenital infections which has to be considered when there is a manifestation of ciliary stalk appearance in the metaphysis. These three infections are congenital rubella, congenital syphilis, and cytomegalovirus. All the three infections can have an appearance of ciliary stalking, that is, longitudinal, dense, and loosened bands alternatively seen in metaphysis. With that, we have seen different presentations of bone infections right from pyogenic, osteomyelitis, tuberculous osteomyelitis, and congenital infections presentations, and their mimickers also we have completed. Thank you for patient hearing. So far we have seen bone infections, that is osteomyelitis of the bone, under the heading of pyogenic osteomyelitis, tuberculous osteomyelitis, and the infections that can present at birth. And we have seen also the differential diagnosis and the mimickers of the disease. with this radiology knowledge, I hope certainly you will pick up the lesions early, and that would help the patient to recover faster. Thank you for listening. Thank you.